Thank you so much, everybody, for having me. Welcome. Today's presentation is called Sepsis Education and Simulation.
There we go.
And just to start off, I don't have any conflicts of interest. An overview for today's session, I'm going to walk us through understanding why the need for sepsis education is both important and challenging. Review the Centers for Medicare and Medicaid Services, or the CMS sepsis bundles. I'm going to be referencing these pretty often. Go through the sepsis simulation case that we built, and talk about the future steps of my project. So first off, why sepsis? I think going back a couple of years ago, there was that very unfortunate case over at NYU of a young boy who came in with a cut. He had some labs drawn. Labs were okay, but the bands came back later. Nobody addressed this, and unfortunately he died. And so ever since then, his parents have brought a big national awareness to sepsis and bringing a campaign, and so the government has been involved in looking at this more closely, including the CDC. So CMS, or the Centers for Medicare and Medicaid, back in October 2015, I was a second year, that's when this started happening, they created a management bundle, kind of like door-to-balloon time or door-to-lytic time with MIs, and looking at how the ED is treating these patients. They're using this as a marker of quality. And because of this quality measure, this is really how hospitals are getting reimbursed for sepsis. So obviously that's catching a lot of attention in hospital administration, and it's trickling down to us in the emergency department and in the inpatient medical units. So it all started back in 1992, sepsis. This is back when Bill Clinton was elected president. My favorite TV show came on the air. And for the first time ever, sepsis had a definition. The Institute for Critical Care Medicine and the American College of Chest Physicians defined sepsis. They came up with a consensus and put out a definition. But since then, because it's been, 26 years now, there have been so many changes in what it means, and the definition is continually evolving as for what sepsis is. There's these CMS measures, which I highlight here, and then there's these Q-SOFA and everything. So every kind of, there's a multitude of papers and variability in the definition. So sepsis has been redefined multiple times. Just a quick refresher, it's kind of on a spectrum. You start with SIRS, the Systemic Inflammatory Response Syndrome, and it's a white count, respiratory rate, fever, or heart rate. If you have that plus the bacterial infection, you're at sepsis. If you have sepsis plus end organ damage, you have severe sepsis, and then septic shock is when you have hypotension or an elevated lactate. This is currently how CMS is defining sepsis. As for the bundles, what they want within 3 hours is a lactate, blood cultures with antibiotics, and 30 cc's per kg of IV fluids, which is drilled into us if the patient is hypotensive or has a lactate greater than or equal to 4. Within 6 hours, they expect you to administer vasopressors if the patient is persistently hypotensive. They want you to reassess a volume status and document your findings, as well as repeat a lactate. Now, talking about the reassessment of the volume status, that includes, you can either do a repeat focused physical exam, this has to be done within 6 hours as well as documented, or you can do two of the following. A couple of those are invasive measures like measuring the CVP and the central oxygen saturation, or you could do a bedside sono with a passive leg raise, but you need to do two. Unfortunately, hospitals across the board, across the country, and this project in particular, I'm working with Susie, so I'm looking mainly at Elmhurst Hospital, where I spend half my time in the emergency department. We're just missing the mark, and we're not meeting these metrics, which is why it's important. This is when it initially came out. In the top graph, our compliance rate in the first quarter, back in the last quarter of 2015, remember these were rolled out in October of 2015, there was only 33% compliance rate of hitting these marks, and it went down as time went on. And on the bottom, you can see this is how well we were meeting the sepsis bundle benchmarks. At first, I guess there was a big push by everybody to really meet these, and in October, obviously, was low. We peaked in December, then it went down progressively from there, and we haven't gotten much better. So the question is, why is this happening? And I think a big part of it is it's very confusing. If you look at this table, and just as a point yesterday, I had an 86-year-old patient. He came in as a STEMI alert. He had ST elevations in his inferior leads. I activated the cath lab. Fortunately, he's nonverbal and bedbound, and the Seaport candidate decided he wasn't a good candidate. He also was being treated for a UTI. He had SIRS criteria, and his initial lactate was 6. even though his blood pressure was okay, he automatically fell into septic shock. And the cath fellow and the senior IM resident looked at me like I had 5 heads. They're like, septic shock, what are you talking about? His blood pressure is okay. So even on the medicine side, and these are Sinai residents themselves and fellows, there's confusion about this because according to he said his boards for internal medicine, that's not how you define sepsis or septic shock. And also when it comes to time in the emergency department, we're getting multiple patients at the same time. While it seems 3 and 6 hours seems like a lot of time to do all those things, it's not when you're getting multiple patients per hour. So I think these are the 2 biggest hurdles that we face in the emergency department. As for my project, so far we've run through 15 residents, EM and IM, only 1 IM resident so far. And I've recruited people from conference, which is the top, and also in some of my free time, I'd go into the ED, and that's Lorraine Bohm. She works in the Sim Center with Susie over at Elmhurst. And we would run a sepsis case in the emergency department. We'd pull residents who were working clinically in the morning and have them run through this case. The novel part about this project is that I included EPIC and documentation, since it's such a big part of sepsis metrics, into the simulation case to see how we were doing. And I don't think we've done that before in either of our sim centers here or at Elmhurst. So participation level by program so far, we did, like I said, have 1 IM intern participate. I'm trying to do more. It's just that the interface for EPIC from the emergency department in medicine is a little different, so I'm trying to figure out the best way to get around that. And we gave everybody a sepsis pretest. When it came to questions about the definitions of what sepsis is, only 48% of participants got those questions right. And when it came to what the bundle metrics were, and people knowing what do I have to do in 3 hours, what do I have to do in 6 hours, only 44% got that right. All right, so my case overview, it was a 55-year-old guy who had very common comorbidities, came in with cough, fever, and nausea. These are his initial vital signs, and right off the bat, this is SIRS criteria. He's febrile and tachycardic. Blood pressure is okay and not tachypnic. Just fast forward ahead, on chest x-ray, he does have a community-acquired pneumonia. So now that we have SIRS and a bacterial infection, we meet sepsis criteria. What we were looking for the residents to do during this simulation case was 1, perform a focused history and physical, administer some oxygen because he was at 95% on room air, administer antipyretics, employ the sepsis order set, mainly 2 sets of blood cultures, a blood gas that had a lactate, chest x-ray urine, and some other markers, give IV fluids, give antibiotics, and document appropriately in EPIC. The case continues. Nothing crazy on the labs. Lactate was less than 2, did have a leukocytosis. So the patient still meets criteria for sepsis by definition, because severe sepsis is these kind of like end organ damage, elevated creatinine, elevated bilis, or coags. But the case after the patient got fluids, he became hypotensive. So now he went into the septic shock category. So then the residents had to address that and administer pressors. So the case ends, and afterward, we debrief the simulation case and their performance. We debrief their EMR charting and what they wrote in EPIC. And we kind of went over, personalized on a one-to-one basis, what the sepsis definitions are, what the bundles are, and what we should be doing in EPIC to reflect the good care we're giving. How did the residents do? When it came to ordering blood cultures before antibiotics, everybody got it. When it came to ordering intravenous fluids as 30 cc's per kg, while we didn't have to do that off the bat, once the patient became hypotensive, that had to happen, and everybody did that at some point. And then determining the patient would require pressors for persistent hypotension after fluid resuscitation, 100%. So at this point, you're gonna pat yourself on the back, right? We did a great job. But unfortunately, that's not the only things we looked at. This is, blue means it was done, red means it wasn't done. So I'm gonna go through each of these really quick. The sepsis order set. This is something that's built into our EMR by our informatics folks. It's really helpful because while it's not necessitated by the bundles, when you're in the emergency department, you're frequently multitasking. You have a patient with a STEMI, you have a patient who's crashing, and then the nurse rolls in with another patient. And they're like, oh, this person is hypotensive and altered, and you need to quickly get some orders in. You need to go on autopilot. So utilizing the sepsis order set, I encourage the residents to do so that you're not forgetting anything, and it kind of checks off all those boxes. Doing bedside sono, 40% of them did that. Since I am doing a fellowship in ultrasonography, I had an interest in that, and we do have a very cool simulated sonography machine that residents can do in real time. And like I said, only 40% utilized. But when it comes to CMS, and we went over this slide before, not only do you have to do bedside cardiac ultrasound, but you have to do another thing, which our residents weren't doing. So that's kind of a lot of work. But thankfully, you can just rely on doing a repeat focus physical exam. And that's kind of easy, it's quick, and you can meet your metrics by doing that. As for the repeat physical exam though, only 2 residents actually performed it. When I made the patient hypotensive after they gave the fluids, 2 residents went back and reassessed the patient. Neither of them documented in the chart, even though I had them go back and like put in orders and stuff. So I feel like we are doing this in real life, and for some reason we're not reflecting it. And the other thing is, one resident did document a note, but she never did the physical exam. She kind of was at the computer and she's like, oh, I know I need to do this, but she never went back to the patient to do the quick physical exam. So when it comes to ordering things, I think we're missing the mark, but when it comes to this actual documentation is an issue. So the next steps for this, and there's been a lot of interventions at Sinai trying to figure out ways that we can increase our documentation rates, because we're only hitting it 30–40% of the time. Some attendings are sending out individualized emails, but nothing's really working. So my next steps are trying to capture at least half of the residents. I did capture a quarter so far. Going over the EPIC chart review. So we're in the process of looking at all of our EPIC charts and seeing how many times we met these bundles criteria, and we're going to really focus on the residents that we've done the intervention on and looking at how their documentation is getting before and after. I know with one resident in particular, a second year after he went through this case, he's so excited every time he sees me to tell me that he's doing the documentation, which is great. And I saw him yesterday. He's like, I saw you did the sepsis note. So he's really excited about that. And then also just doing some post-testing. So 3 months after the initial pre-test, we're doing a post-test, seeing if their knowledge has improved at all, and so we're still in the process of gathering that data. It is a tricky thing, and I'm not sure there's a correct answer for how to get us to the correct sepsis marks and metrics that CMS is looking at, but we're working on it. So with that, that's my references, and I just wanted to say a big thank you to the Institute for Medical Education for having me here in the Harvard Macy, as well as my mentor, Susie Bentley, and Lorraine, who works with her in the SIM Center, Dr. Karani and Soriano, and Maggie, too, who's been in touch with me for emails. So now I'd love to answer any questions that you have.
Nice to meet everyone. Again, I'm Kamron. I'm a third-year GI fellow here. I really want to thank the Institute of Medical Education, actually, for allowing me the opportunity to go to Harvard Macy a couple years ago and complete that program. I found it to be extremely formative for me, and actually to come back as well this year. It was a really great opportunity, and I encourage anyone who's streaming this and who's thinking about applying to really do that for the upcoming year. So the title of my talk is A Qualitative Assessment of Endoscopic Teaching Behaviors. I don't have any disclosures, obviously. 2 major learning objectives for this. The first one is to really discuss the current landscape of endoscopic teaching behaviors and what's in the literature right now, or what's not. And then the second point is to really describe the qualitative research technique that I used in my project. Brief outline for the next few minutes. We're going to start off with an overview of teaching endoscopy, what the setting is like, who the players are, the aim of the Harvard Macy project that I completed. This project actually has 2 phases, phase 1 and phase 2. We're going to talk about both of them, the methods, results, and discussion of each sequentially. We'll start with phase 1, and then we'll move to phase 2, and then we'll finish off with the future directions. So a little bit of background. So as a gastroenterologist, a big part of what we do is endoscopy. It's a procedure-oriented field. Endoscopy includes upper endoscopy, or EGDs, and colonoscopies. A unique part of GI training is the fact that you come into GI fellowship having done 0 endoscopies. And so unlike maybe some other exposures you may have in medical school, placing IVs or helping out in the OR, you really don't have any exposure to that before stepping foot into a GI training program. However, during the course of 3 years of fellowship, you have to go from day 1 of doing 0 endoscopies to at the end of 3 years being competent in performing endoscopy on your own for unsupervised practice. And that's really important to highlight, because that only just highlights the importance of having really effective endoscopic teachers during those 3 years to really meet that end goal. There are cognitive and psychomotor components to both learning and teaching endoscopy. This is not dissimilar for any other procedure-oriented field. Endoscopy is kind of a middle ground in terms of hospital procedures that we do, maybe a little bit more advanced in bedside paracentesis or IV placement, a little less involved, obviously, than being in the operating room and using a scalpel. Here's a quick snapshot into what it's like to be in an endoscopy suite. So what we have here is the trainee over the right side. He's holding a scope in his hand. Looks like it's an upper endoscopy. Based on the patient's positioning here, the patient's sedated, laying on the table. We have the care team. This includes usually a nurse in the room, a tech to kind of help out with different supplies and equipment, and often there's an anesthesiologist in the room as well, depending on your institution, to help out with sedation. Somewhere lurking about that room is the attending. So here, kind of hidden out of view, everyone's has their own type of style about how they want to be present. And the focus here is going to be endoscopic teaching behaviors from the attending. Everyone's kind of focused on the screen here. This is the hallmark of endoscopy. Endoscopy is a flexible camera. We place it into the intestinal tract, and we're seeing what's happening on the screen. We can either diagnose pathology or treat pathology based on what we see on the screen. So this is kind of, as you can see here, it can get kind of hectic in the room. This is not very dissimilar from what can happen in like an ICU case. Everyone's very crowded all together. And it's really the attending responsibility to kind of manage the needs of many people. One being the needs of the learner, making sure they're actually growing in competence and performing the skill. The needs of the patient, making sure they're adequately taken care of during this. And really the needs of the healthcare system as a whole, making sure they're really giving like cost-conscious care and efficient care to make sure that room turnover happens to not, delay other patients' care as well. So when we look at endoscopic teaching behaviors in the literature, pretty much everything that's been published has been in the teaching perspectives of supervising physicians rather than a fellow-driven perspective. This includes both GI-focused training programs as well as surgery residencies. In general surgery, they need to get signed off on a certain amount of endoscopies, and a lot of these perspectives are from supervising physicians. There are no studies that describe what behaviors can facilitate or impede endoscopic learning for the GI fellow. Therefore, that was the focus of my project, to describe the endoscopic teaching behaviors that exist in GI fellowship programs and their positive or negative impact on GI fellows' perceptions of learning. So again, this is a two-phase, this is a double hitter here, okay? So phase one, this was what my application to Harvard Macy was based on. I'll go into more detail on this, but basically it was a content analysis, a qualitative study, looking at feedback data from fellows on attendings and their endoscopic teaching abilities. Using this data, I then performed a second study to look at the learning impact of behaviors and how important they were on from the perceptions of all the active players. So for the first study, a prospective descriptive study, the participants were GI fellows in 2 academic programs. We partnered up with UCSF on this one. However, almost majority of the data was from Mount Sinai. The intervention were feedback cards, which I'll show you in the next slide, that were filled out at the conclusion of endoscopy, either inpatient or outpatient, from fellows voluntarily on their supervisor's teaching ability. The data collection period was over about 9 months. So here's a snapshot. This is the actual card that we had printed out on cardstock. As you can see, I'm not sure if you can read it from afar, but there are 2 prompts. The 2 prompts read, list 2 things that your attending did well during endoscopy that you found enhanced your learning. The second prompt is list 2 things that you thought hampered your learning. The attending field was optional, though it was filled out most of the time. And the fellow year there is also listed, fellow year 1, 2, or 3, which corresponds to fellow year PGY level 4, 5, or 6, respectively. Fellows were instructed to fill this out voluntarily. They didn't have to fill out every single thing. They could fill out just 1 positive behavior or 1 negative behavior, whatever they wanted on a voluntary basis during their endoscopy time during fellowship. So at the end of our data collection period, we had information on over 30 attendings, comprised which were from 19 GI fellows. Most of the responses were from PGY 4 and 5 level fellows, so over 80% of comments were from junior fellows, which isn't surprising given the fact that Mount Sinai and UCSF are research-focused fellowships, where the bulk of your endoscopy time is in your first couple of years. Your third year usually is protected for research time, so that wasn't surprising. You can see 3% of fellows just forgot to circle what fellow year they were on the card, so I couldn't really quantify that, obviously. Could guess based on handwriting, but we're not going to go there. So what do we do? So I have this stack of feedback cards, right? Like, what do I do with this? And so I learned for the first time, research methodology and qualitative research. And so my mentor, Bridget, really helped me out a lot with this, as did Justin Sewell at UCSF. And a basic understanding of a conventional content analysis or qualitative research as a qualitative research method is that you really immerse yourself in the primary data without any preconceived notions of what you'll find, and kind of different categories and themes will emerge as you really immerse yourself within the data. And you basically take very subjective behaviors And the goal is to really categorize that objectively to be a springboard for further study. It's basically like what I hope to set out with this study. So after all these feedback cards were completed, we basically wrote down verbatim each of those comments, direct quotes, on an Excel spreadsheet. And then I read them over and over again. I then reflected on that, wrote down my reflections, thought about my reflections, and then went back to the comments and really just kind of like went knee deep in these comments. This was done by two of us. We did this separately. And through this process, we started to come up with different categories of what may be happening in these behaviors. That we call them behavior codes. After we developed these behavior codes, this will make more sense than maybe the next slide, we also met to make sure that we were on the same page. So we both sat down and we basically verified that if there are any discrepant codes, we reconciled them and came up with a finalized set of codes. From these codes, we then took it another level through the same process and came up with overarching themes. So kind of working your way up a pyramid of many behaviors, fewer codes, even fewer themes as a way to kind of categorize these behaviors. So at the end of our study of phase 1, we had 239 individual teaching behaviors. We translated that into 29 codes. And from those 29 codes, we came up with 7 themes of endoscopic teaching behaviors. Here's a snapshot into a few of these. And so starting from left to right, we're working our way up this pathway. And so you can see here on let's take the theme of teaching. This is direct teaching. Discussing guidelines for number of biopsies to take. We call this knowledge expansion. Tell me how to retroflex in the cecum, which is a specific technique. Procedural skill development. Consider the differential diagnosis prior to starting. Clinical reasoning. That's when we came up with our codes. Eventually, once we looked at all our codes, all these codes fit under the umbrella of like teaching. Same for learning environment. Very patient, patience, looked at the screen the entire time, involved, creating a safe learning environment, supportive. All these codes fit under a learning environment category at the end of our study. So after this was done, here's another table looking at the valence, so either a positive or negative impact on learning. On the x-axis is all of our themes, the 7 themes that we developed. Most of the themes are under teaching, learning environment, or autonomy. On the y-axis, the end there is the number of individual teaching behaviors. So back to that granular component in the very beginning. What we can see here is that most of the comments that we gathered were positive, overwhelming amount were positive. Most of them were in those three major domains. The highest number absolute number of highest negative comments were in the realm of autonomy. And this was just kind of like a nice basic snapshot into what happened with that study, basically. So for this first part of the study, the strengths being, well, this was the first time that endoscopic teaching behaviors were ever described from the GI Fellows perspective at all in the literature. Limitations being, one, this wasn't really a multi-center study because 93% of the data actually came from Mount Sinai, 7% from UCSF, so I can't really call it like multi-center. Another limitation here is that I just have absolute number of teaching behaviors, right? I have an absolute count. I don't really know if that really translates to any actual learning competency or change in learning behavior or outcomes clinically. There's just like a number in an observational study. We can maybe infer that direct teaching and preservation of autonomy appear important to trainees, but we have to kind of delve into that a little bit further. Perceptions from trainees can provide insight into which behaviors are helpful and which are not. And it is possible to create a thematic categorization scheme to endoscopic teaching behaviors. So this is the end of the first study. So then I had to think about, great, I have these 7 themes. What do I do with that, right? How do I know which ones are important? So then I sent out an electronic survey using a Likert scale to help stratify the importance of these behaviors. And I used all those 29 behavior codes as prompts of like actual performing a behavior. Send this out to fellows and attendings. The 2 prompts for this Likert scale were choose the extent to which each teaching behavior impacts effective endoscopic learning for the fellow. Effective endoscopic learning was defined as a successful transfer of knowledge or growth in a specific skill or attitude. The Likert scale went from 1 to 5, 1 being no impact and 5 being crucial to learning impact. The second prompt on this survey was choose how often you encounter or perform these teaching behaviors during endoscopy, depending if you are a fellow or an attending, 1 being never, 5 being always, just to kind of see how often these things are happening, more out of curiosity. At the end of this survey that was done, we sent out to 88 people. We got over a 50% response rate. The survey tool we used was Qualtrics. The demographics are listed here. So majority were attending responses here, which is not surprising given the population initially. And most of these attendings were senior physicians that had at least 6 years of teaching experience in endoscopy. The fellow breakdown is here. For the behavior impact, all all behaviors were deemed as having some learning impact. So they all ranked 3, at least a 3 on the Likert scale. And majority of them scored a 4 or higher for both attendings and fellows. The top 5 concordant behaviors between attending and fellows, all of these scored a 4.3 or higher for both attendings and fellows. They're listed here, demonstrating unfamiliar endoscopic techniques, discussing endoscopic findings in real time, demonstrating patience, supportive learning environment, and displaying respect for the patient. For the behavior frequency, a little bit more heterogeneous there with the results. So attendings scored higher than fellows. So basically, attendings thought they were performing these teaching behaviors at a higher level than if fellows thought their attendings were performing them. However, there was no discrepancy greater than 2 points on that Likert scale. In fact, there's only one greater than 1.5, and there are only 5 behaviors that were greater than 1.2 of a discrepancy between attendings and fellows on the Likert scale. They're mentioned here. So from this, strength being from this is that I was able to get some data objectively about how impactful these behaviors were in a quick survey. Limitations being that this is the attending response rate really pales in comparison to the fellow response rate, as well as the fact that this is really subjected to significant recall bias on this survey. However, all behaviors identified in phase 1 of the study were found to have at least some impact on endoscopic learning. And though attendings perceive a higher frequency of teaching behavior performance compared to trainees, overall, there's a high level agreement for which behaviors are important and how often they are performed. So what do I do with this now? So I was actually able to get a grant through the AGA, which is the American Gastroenterological Association, for the creation of faculty development tools based on the initial data that I had from this. And so what we're developing right now is an online smartphone-friendly attending endoscopic teaching feedback tool. So basically take that card that I initially used and kind of make it more granular using the themes that I've now identified to kind of make it easily accessible for fellows to provide feedback on our attendings in real time and increase the volume of our feedback to our attendings so they can actually make changes. And the second part of this is we're going to develop a workshop using role-played videos based on the behaviors I identified, role-playing good and bad teaching behaviors, focused mostly on the learning environment, teaching, and communication, to hold a workshop using these videos and kind of group discussion to kind of really improve these behaviors. So that's my project. I really want to thank the IME again for giving me this opportunity, Dr. Karani, Maggie for putting up with me, the Harvard Macy program itself, all the great co-facilitators there, which are really amazing, Bridgen, my PI, Lori Kiefer, who helped me out with survey method, Justin Sewell over at UCSF, Satish, who's a great clinical mentor of mine right now, and the whole MSH GI division for just putting up with me and all my emails over the past couple of years. So thank you for taking interest.